So today I'm going to talk with you all about 3D tomosynthesis. First, we'll start by just talking about breast cancer screening in general, and then we'll go into some of the challenges of 2D mammography, which will lead us into talking about tomosynthesis, what it is and how it can help, and also what are the limitations of this technology. We'll go through some examples as well, and then I was asked to talk a bit about breast density because with the relatively new legislation in North Carolina, it's a hot topic right now. So why do we screen? We screen to reduce mortality. So there is a mortality reduction of 40% from annual screening mammography ages 40 to 84. So that's very significant. And that's because we're able to find cancers at a smaller size and earlier stage. So who should be screened? Well, in radiology, what we recommend is yearly screening mammography beginning at age 40. And it's not just us in radiology, there's other groups as well that abide by the same recommendation, including the OBGYNs, the American Cancer Society, as well as the AMA. And in radiology, as far as when you should stop screening, basically what we recommend is if a patient were called back from screening mammography, if they're willing to do the additional tests, and if we recommend a biopsy, if they're willing to do that, we would recommend screening in that patient. So what are the challenges of 2D mammography? Well, unfortunately, screening mammography is not perfect. After 10 years of undergoing annual screening mammography, over half of women will receive at least one false positive recall, and 7 to 9% will receive a false positive biopsy recommendation. So this can cause a lot of anxiety, and we want to do better. One of the challenges of 2D mammography is patients with increased breast density. So this is because the sensitivity of mammography decreases as breast density increases. And this is important because patients with increased breast density have an increased risk of breast cancer. And also the population with higher breast density tends to be younger. So just to give you a visualization of what I'm talking about, here's everybody who comes in for a screening mammogram. What we do is divide their density into 4 categories here. Almost entirely fatty, scattered areas of fibroglandular density. And you can see here we have this gray fatty tissue, and as we go up in this direction in density, we're getting more of the white glandular tissue. So those two are considered not dense. And then we have the categories of heterogeneously dense and extremely dense. And if you fall into those 2 categories, you are dense. So the problem with breast density is the density of cancer can be the same as that glandular tissue in the breast. So if we go back here and I'm looking for a small white mass, well, I'm probably going to see it in this breast, surrounded by a sea of that gray fatty tissue, compared with this breast where it's surrounded by white glandular tissue. So you get this effect of looking for a snowball in a snowstorm with dense breast tissue. So what are some improvements that have been made so far? Well, film screen versus digital mammography. So digital mammography is more accurate for women under the age of 50 and those with dense breasts and premenopausal or perimenopausal women. So we've made some improvements in that patient population with dense breasts, but again, we want to do better. So that leads us to the main topic for today, 3D tomosynthesis. So what is it? So this is a schematic here of what it would be like to get a 3D tomosynthesis examination. Here's our detector, and this is the breast, and here's the compression plate, and here's our tube, and this tube is supplying x-rays that will go through the breast to the detector. So in a 2D examination, this tube would be stationary, and you'd take one projection. In 3D tomosynthesis, the tube rotates and takes multiple projections in an arc, and from that information, 3D image is reconstructed. So this is a picture of one of the actual machines that will perform 3D tomosynthesis. And again, here's your detector, the compression plate, and your tube rotating. So for the patient, the experience is very similar to a 2D mammogram. They're positioned exactly the same way, and they stay in that position for the 3D tomosynthesis image. In fact, sometimes patients aren't even aware that they obviously are signing up for the 3D tomosynthesis, but aren't aware when it's happening. The system we use at Wake Forest, for each image, it takes 3.7 seconds longer, so not a whole lot of time. So here's a picture of a 2D mammogram, a standard 2D mammogram, and then this is 3D tomosynthesis. So I'm going to click on this, and you'll see we're actually going through slices of this 2D image. So we're able to get a lot more information. And these slices are very small. They're 1 millimeter. So we're really able to evaluate the breast, especially dense-breasted women, better. So what are some of the benefits? Well, the benefits of 3D tomosynthesis have been shown when it's used in addition to the normal 2D mammography. Tomosynthesis improves accuracy. So it's helpful in increased cancer detection. So some studies have shown 15 to 20% increased cancer detection, specifically invasive cancers. So that's important. But not only does it do that, but it can also decrease our false positive recalls. Remember, we want to do better with that. We want to decrease patient anxiety. And studies have shown somewhere between a 6 to 67% reduction in recall rates. Most studies show between 30 and 40%. Tomosynthesis can also localize lesions. Sometimes, especially lobular cancers, we may only see an abnormality on one view. But with the 3D tomosynthesis, we're able to look at which slice of the breast that abnormality is in and then localize the lesion. And this may mean that they don't need as much imaging when they're recalled because we know where that lesion is already. Also, it helps to better detect architectural distortion. Architectural distortion, and here's an example of it here, you can see sort of wispy lines radiating from a central point. And that can be difficult to see on 2D mammography. But when you get these 3D images, often if it's present, it will really pop out at you. And this can be a sign of breast cancer. Also, 3D tomosynthesis helps us better evaluate the margins of a mass. So we know what our suspicion might be. Is it nice and circumscribed, or is it spiculated? And this can also help us not need as many mammographic images when a patient comes back as a recall. But with every technology, there's also drawbacks or limitations. So with tomosynthesis, we are using more radiation. And the radiation is about twice that of 2D mammography alone. But it's still well below the dose mandated by the Mammography Quality Standards Act. Also, like I said, although we're increasing the radiation initially, if a patient is recalled, we may not have to do as many mammographic views to work up the patient. And all this being said, there's a new technology out there that can actually synthesize 2D images from 3D images. So as that grows, we actually will not have that downside of increased radiation with 3D tomosynthesis. Another drawback is sometimes benign lesions can be more conspicuous with tomosynthesis. For example, if a patient with dense breast had a cyst, we may not see it on 2D mammography, but it may come out on 3D mammography. But remember, overall, we still have a decreased recall rate. And one of the limitations of 3D tomosynthesis is in the evaluation of calcifications. So this is one of the reasons that 2D mammography is so important. Calcifications can be benign, but they can also be a sign of cancer. So we have to look for those calcifications, and we need 2D mammography for that. And on our end, we see a lot of increased interpretation time. So studies have shown it takes about double the amount of time to read a 3D mammogram versus a 2D mammogram. And this makes sense because instead of one image, you're looking at multiple 1 millimeter slices of the breast. And also, of course, everything comes at a cost. So let's look at some examples. This is a patient who came to us for screening mammography. And on the 2D image, you can clearly see that there's a mass in the inner breast here. And on the 3D image here, as we go through, you'll see this mass, and you can tell it's spiculated. But also, I'll draw your attention to this area. And you see 1 and 2 other masses in the breast. So here's a slice from her 3D image showing those 2 additional masses that we can see. So this was important. We already knew the patient had to be recalled, but now we know that there's multiple masses in the breast. So we know to work her up for those multiple masses, and knowing that can change her surgical management eventually. She did get worked up with ultrasound, and each one of these orange arrows points to a different mass that was found in the breast. So she was found to have a total of 4 masses, and she was found to have invasive breast cancer. Here's another case, and on 2D mammography, we see this abnormality here in the lower posterior breast. And on 3D mammography, we get a much better look at that abnormality, and we can tell the margins of the mass. So let me blow that up for you. Here's that spiculated mass. So this is a slice from the 3D tomosynthesis images, and this is that mass blown up. So we can clearly see on 3D imaging the spiculation of that mass, which was not apparent on the 2D. And she went on to have an ultrasound, which turned out to be negative. Then she had an MRI showing that mass, and it was biopsied and showed invasive breast cancer. And we'll go through one more example here. This is a screening patient, and just to point out, this patient does not have dense breast tissue. A screening patient, no abnormality on 2D mammogram, nothing apparent. And then on the 3D mammogram, I'll draw your attention to this area here, and you start to see all these wispy lines. This is architectural distortion. So I'll let this run through again. So architectural distortion. And again, this is a slice from that tomosynthesis imaging, and you can see these radiating lines, which represent architectural distortion. And she went on to have an ultrasound, which showed a mass in this area, and she was biopsied and had invasive breast cancer. So let's go ahead and talk about breast density for a second. So here's just a reminder. We have our not dense breast with gray fatty tissue working all the way up to our extremely dense breast with all this white glandular tissue. So about half of the states now have legislation saying that you have to notify patients of their breast density. So here, all these pink states have the legislation, and including us in North Carolina, and the blue states are working on such a law. So if a patient gets their mammogram, gets their screening mammogram, they always get a letter with the result. But if they have dense breast tissue, they also get an extra paragraph in their letter. So it says you may have dense breast tissue. This is relatively common. It can be more difficult to detect abnormalities. You may be at increased risk for breast cancer, and it encourages you to talk with your physician. So you can imagine that if a patient reads this, they may be very concerned that you're telling them it's more difficult to detect abnormalities, and you may be at risk of increased risk of breast cancer. So I just want to take each one of these statements and sort of explain them. So first is you may have dense breast tissue. So that's a little confusing as well. You'd think either you have dense breast tissue or you don't. If we go back to this slide here, there's a little bit of a gray area between scattered areas of fibroglandular density and heterogeneously dense. Most of the time, a reader is going to call one or the other consistently, but there's a lot of, if a patient is right in between, one day they may call them scattered areas of fibroglandular density versus heterogeneously dense. And what about density of breast tissue is relatively common? Well, that's true. If you look at heterogeneously dense and extremely dense breast, you'll see that half of the population has that. So half of the population has dense breast tissue. So it's very, very common. And what about more difficult to detect abnormalities? Well, we touched on this a bit earlier. So if you have a breast that's almost entirely fat replaced, your sensitivity of mammography is 87%. For extremely dense breast, it's 63%. So again, it's that concept of overlapping breast tissue masking some small masses in the breast. And what about this concept of increased risk? Well, first of all, what is that increased breast density? What does it represent? What it represents is increased epithelial and stromal elements. So most cancers arise in epithelial cells, so if you have more of those, it would follow you're at an increased risk. And in the literature, there's a lot of numbers out there as far as what's the relative risk for a person with dense breast tissue. Well, it all has to do with who you're comparing them with. So if you compare a heterogeneously dense-breasted woman with an average woman, your relative risk is 1.2. An extremely dense-breasted woman with an average woman is 2.1. So they are at increased risk, but it's not as much as some other factors such as age, family history, reproductive history, and genetic mutations. And also, at the end of our mammogram report, what we do is kind of summarize what the patient will get in their letter and also refer patients and physicians to this website here. And it's a great website and has reliable information. So in these patients who come in and they want to know, what else should I do? I have dense breast tissue, I'm concerned. Should I have another screening test? Well, your options to think about would be whole breast ultrasound, MRI, or tomosynthesis. So let's talk about whole breast ultrasound first. There actually are not any randomly controlled trials to evaluate the use of supplemental screening with whole breast ultrasound to detect cancer in dense-breasted women. And with whole breast ultrasound, the incremental cancer detection rate is 2 to 3 per thousand. So with mammography, it's 5 per thousand. But with whole breast ultrasound, the big concern is the low positive predictive value, which is between 6 and 7%. So if you used whole breast ultrasound, and again, it's important to stress this is for low and average risk women. If you used whole breast ultrasound, you're going to have a lot of women coming back for follow-up or biopsy with benign results. What about MRI? Again, we suffer from lack of evidence in the literature. There are no studies that evaluate the benefit of adjunctive screening MRI in women with dense breasts and negative mammograms. But this study is underway and is expected to be completed in 2019, so we'll stay tuned for that. And MRI has very high sensitivity. It's great at detecting cancers. But the problem is it's low specificity. So again, there'll be a lot of follow-ups and biopsies in this low to average risk population of women that are unnecessary. And the specificity of MRI varies quite a bit in the literature. Mostly it's between about 50 to 70%. So what about tomosynthesis? Well, the results are very promising for tomosynthesis. One study showed the gain in the area under the ROC was 2 to 3 times higher in women with dense breast than fatty breast, again when you use that 3D imaging with 2D imaging compared with 2D imaging alone. And this is thought again to be that decrease of the effect of superimposition of tissue. So let's look at this patient here who came in for a screening mammogram, dense breast tissue, normal 2D mammogram. She got a tomosynthesis imaging done, and I'll draw your attention to up in this area here. And you'll start to see here these little wispy lines. And this is a slice from her tomosynthesis imaging showing these wispy lines coming from a central point. So she had architectural distortion and was found to have an invasive breast cancer. And we would have never known on her 2D imaging. And this patient, she doesn't have dense breast tissue overall, but this area has increased breast density. And not a lot was seen for sure on her 2D mammogram, but on her 3D mammogram, there's a very definite abnormality here. You can see all these wispy lines. And she had architectural distortion. And here's a slice from her 3D image, better showing that. and she was shown to have invasive breast cancer as well. So what do we recommend for these women with dense breast? Well, right now, multiple societies, and you can see them all here on the bottom of your screen, not only Radiology, OBGYN, American Cancer Society, etc., do not recommend supplemental screening of women with dense breasts who are average or low risk. In our reports here at Wake Forest, we do put a sentence at the bottom in patients who we've said have dense breast, and we say consider mammogram with 3D tomosynthesis next year for all of those reasons that we've described so far. So hopefully today I've explained to you just some general things about breast cancer screening, some of the challenges of 2D mammography, and how 3D tomosynthesis can help us, and what its limitations are. And also, hopefully I cleared up some things about breast density.